diagnosis when you do a biopsy. There's the radiological diagnosis, and I don't really understand what that means myself as an old guy, but sometimes after an ultrasound or a CT, they'll say there's cirrhosis, and I look at the labs and there's no damn cirrhosis. So I don't know what that means, but clinical cirrhosis, in my mind, is the factory is not working. And we had evidence that the factory is not working because the albumin was low and the INR was significantly high. And those are the two things that I'm looking for, because there are other explanations for a high INR and there are other explanations for a low albumin. But those two things together said something's really bad going on in this liver. Then we looked at the labs and we had mildly elevated transaminases, maybe 3 times normal, 4 times normal. What we didn't do that I wish we had done, and there's always different ways to discuss and get to the bottom of any case, is to say, okay, what is the differential in, I believe it's a 50-something-year-old woman who has elevated transaminases. And so, and I do this on rounds periodically. I say, okay, let's think of all the liver diseases that could represent this. Could this be a smoldering hepatitis C? So we have to think of hepatitis C and hepatitis B, smoldering, what we used to call chronic active hepatitis. So that would have been a possibility. Could this be an infiltrative disease? That's a little unusual with these particular numbers, but we had to consider that when we did imaging. Could this be primary biliary cirrhosis? This was the right age, the wrong lab values. We should have seen a much higher alk-phos, and they usually present with itching. Could it be primary sclerosing cholangitis? Very unusual in women, no history of ulcerative colitis, and again, the numbers weren't right and the ultrasound wasn't right. And then could it be hemochromatosis? Very unusual in a 50-something-year-old woman. She's way too old for Wilson's disease. That usually presents in the early 20s or late teens. So at that point in time, you have to say, could this possibly be autoimmune hepatitis? And autoimmune hepatitis used to go by the term leukoid hepatitis. I don't know if anybody in the room knows that, but that was the old name for autoimmune hepatitis. And so they then looked for autoimmune hepatitis, found all the right numbers, and found out she did have autoimmune hepatitis. This is a relatively good diagnosis to make because it does have a treatment. And so the thought process was quite good. That they did an echo, they looked for elevated right-sided pressures and excluded right-sided heart failure. And so all the focus had to go on the liver. And I think in retrospect, we might have paid a little more attention to the liver tests, come up with a differential based on the liver tests. I don't know if do we have a schema for that, Reza? But a schema for elevated liver tests might have listed all the different things that we'd have to consider. And it is then logical that you'd order the test for autoimmune hepatitis. I hope that helps.
That is super helpful. Leukoid hepatitis. I love it. Thank you so much, Uncle Bob. Very nice reflection. We're all about space learning and continuously trying to improve and grow. And for those of you who don't know this, Uncle Bob actually missed that session. He went back and listened online and then shared his amazing pearls on his Twitter account @MedRants. Highly recommend you follow him. So Moses, can you take over the screen now? Brian, thank you so much for volunteering to present a case. Let us unmute you. I'll have Moses or Jack unmute you. If you don't mind, just introducing yourself, tell us who you are, and maybe something fun that's happened to you over the past week.
Awesome. My name is Brian Ulrich. I'm an M4 at Emory currently. I'm going to be applying to IM in the fall. I'm really trying to kind of take advantage of, staying at home for a while. So I've been cooking a lot more. And I really like candles. So I've been lighting just tons of candles every day. So really trying to take advantage of it.
What's your specialty dish?
It's a great question. I've just been trying to make a lot of like soups and stuff. So I've been making matzo ball soup the past few weeks. But I like everything,
And another question I have to ask you, have you
Yes.
worked with Kimberly Manning?
I have. So I don't know if you know, like her whole like beast mode talks that she has people give. So she actually started a medical school teaching competition at Emory, and I participated in that my second year. So huge fan of Dr. Manning.
That's amazing. Bite-sized teaching, nothing like it. She's one of my idols. So let's get Greg. Greg, can you please unmute yourself and introduce yourself and tell us who you are, something exciting that happened over the past week?
Yeah, I'm Gregory. I'm a fourth year at UCSF, starting my fourth year. So I'll also be applying into medicine in the fall. I'm on my medicine sub-I right now at SFVA. So what fun things haven't happened. But I did get 2 days off this weekend by discharging all of my patients, and I earned myself a day off. I've been playing a lot of board games by Zoom, actually, which has worked out surprisingly well. Yeah, so actually I'm able to play more often now than before shelter in place.
Gregory, thank you so much for that introduction. I should have asked you if you prefer Greg or Gregory. I made that mistake.
Oh, Greg is good.
Oh, which one do you prefer though?
Greg.
Oh, Greg. Okay, so I assume my mistake was right. I should have asked though. Bhavya, if you don't mind introducing yourself, telling us where you are and something fun that's happened over the past week.
Sure. So I'm quarantining at home in Charleston, South Carolina. Good weather. So I'm really enjoying that. Like Brian, I have been cooking a lot with my mom, who does not like to use measurements or recipes. So it's been nice that I can spend a bit more time with her to learn some good stuff. I am also a graduating MS4, and I'll be at Hopkins for medicine in the summer.
Oh, wow. Very nice. Am I pronouncing your name correctly? Is it Bhavya?
Bhavya.
Bhavya.
Yes, perfect.
And before we get the case started, Brian, I want everyone to wish Ravi a happy birthday. He's just joined the chat. He's going to pair up with Greg and respond to the first aliquot. But, you know, the clinical problem solvers would not exist without Ravi Jha. He has been the engine, the motor behind the entire operation. So I did have an Allagash White right before this session. Cheerings to Ravi Jha. All right.
Happy birthday.
Brian, please take it away. Now that he's here, we have to put him to work.
Awesome. So this is a 65-year-old man who's presenting with 2 weeks of vomiting. And do y'all want the rest of the HPI? I'm sorry.
Yeah, why don't you give us more of the HPI?
Cool. So he was actually hospitalized 3 weeks ago for his third unprovoked lower extremity DVT in the past 5 years. That had been worked up pretty substantially to really no avail, and he had been on dabigatran kind of off and on. So at discharge, he was put back on dabigatran. Shortly after discharge, he began to have significant difficulty just keeping food down. He would throw up shortly after eating, but he was able to keep some liquids down. 1 week before presentation, he presented with this issue to an outside clinic, underwent a barium swallow, which he said was normal, and he was prescribed Zofran, which he said slightly helped, but really he had vomiting after every meal. And then the day before admission, he threw up 5 times over the course of the night, and he decided that he would present to the hospital. He said that on presentation, his vomit was non-bloody, but he didn't have a great sense of the color of it. He endorsed weight loss over the past few weeks, but denied any abdominal pain, constipation, feverish chills, headaches, or dizziness, or any recent changes to his diet.
Brian, thank you so much for that information. I didn't get a chance to hear a little bit more about you, but I can already tell that with what little I get to see that clearly you have a great understanding of this case. Thank you for bringing it to us here. Greg, hello. Long
What's
time
up, Robbie?
no see / speak. It's only been a good 12 hours. It's great to see you. I'm curious, we got a lot of information. We got a lot of information about the background potentially with the unprovoked DVT on dabigatran, and then a fair amount of information on the foreground. So why don't you just focus on the foreground for now and tell us where this story is taking you?
Yeah, so this is an older gentleman, recently started a new med, who's coming in with, sounds like worsening progressive vomiting. No real localizing GI symptoms, no localizing infectious symptoms, but it's now progressed to the point where he's throwing up, quite a substantial number of times. I think throwing up at night is always raises my suspicion a little more. People like to sleep. And he's also kind of resistant now to Zofran, which seems to be helping, but not enough. So in terms of where I'm looking for a problem, barium swallow is normal. Nausea can be caused by a large variety of things. I don't know. Anytime patients are started on new meds, I get a little suspicious about the med, and he doesn't have anything else going on. So that's where I'm looking first.
And I think that your analysis reflects the challenge that anyone has with a complaint of vomiting and vomiting alone. And I commend you for stepping back and saying, well, what's happened recently? And it's hard not to reflect on the high chance that medication can induce nausea, and the list of medications that induce nausea is probably every single medication, quite frankly. Like, can you think of a list on a pamphlet or on Up to Date that doesn't have nausea and vomiting on it? And so I think that is an important association to have. Of course, certain medications will probably trigger a more profound association with nausea and vomiting, but that'll be something that we have to analyze. The challenge that you and I are facing, Greg, is that most progress of a patient with nausea and vomiting does not come from studying the nausea and vomiting. It comes from studying the company that it keeps. And so the question is this headache plus nausea and vomiting, chest pain plus nausea and vomiting, abdominal pain plus nausea and vomiting? And believe it or not, I've seen podagra from gout with nausea and vomiting, literally from head to toe. And the question is, where can you draw the line from head to toe to localize the source of nausea and vomiting? And that's where you need an accompanying symptom. Here, we don't seem to have one, although I'll clarify that in a second. And so if you don't have an accompanying symptom, you then have to be like, whoa, I'm out of luck today. I need to prioritize the absolutely no miss causes of nausea and vomiting that tend to sneak up on people. There's a fascinating case of a New York Times diagnosis column and somebody who had a posterior fossa demyelinating lesion right at the nausea and vomiting center. It's called the area postrema. And maybe we can send out a link. I'll put the link in the VMR website. It's fascinating. Just right there causes nausea and vomiting. Another presentation of nausea and vomiting that I've seen multiple times now is a myocardial infarction. Just nausea and vomiting. And of course, there are risk factors for atypical presentation in those patients. I'd say there are a couple of electrolytes to keep in mind as just nausea and vomiting. Significant hyponatremia has fooled me before. Would nausea and vomiting be the primary manifestation, as has uremia. I've had a patient who's like, I'm just not feeling right, nauseous, vomiting, and their creatinine comes back at 5. So that's my checklist for severe things that can sneak up on you as nausea and vomiting. You won't be surprised that there's a long list of medications, toxins like cannabinoid hyperemesis syndrome and other rare things. In fact, Reza had a fascinating case of an abdominal migraine that presented with predominant nausea and vomiting. But I'm not confident that this is isolated nausea and vomiting. I'm a little worried that we actually can localize the lesion here to the upper GI tract. And the reason that is if you study profuse nausea and vomiting, just the sheer amount and the food intolerance, it really focuses on one of three things: ICP elevation, ACS, or a proximal small bowel / stomach issue. So yeah, it appears like it's isolated nausea and vomiting. But I'm a little worried that there might be something going on in the upper GI tract. But we definitely need more information to get to the bottom of that. So Brian, I'll pass back the mic to you if you wouldn't mind fleshing out the past medical history and all the way up until the exam.
Yeah, absolutely. So the past medical history, the recurrent unprovoked DVTs, which, as I had said, they had been worked up and nothing really came of that in the past. He has had gout in the past. And he has diet-controlled type 2 diabetes and diet-controlled hypertension. The meds, just dabigatran and Zofran. The family history, he did say that multiple family members had a history of unprovoked DVTs, but none of them had a specific diagnosis. He denied any family history of cancers. His social history, he's a recently retired police officer who lived in a home in the southeastern United States with his wife, denied any recent travels or recent changes to his diet. He endorsed a 10-pack-year history of smoking, which he quit over 30 years ago. He denied alcohol or recreational substance use. He specifically denied any marijuana use, and he was sexually active with his wife.
And Brian, do you mind taking us through the physical exam?
Absolutely. So the temperature was 36.9, the heart rate 79, the blood pressure was 124/75, the respiratory rate was 16, and he was satting 97% on room air. The weight was down 10 pounds since his discharge approximately 3 weeks ago. Generally, he was well appearing and no acute distress. HENT, he had anecteric sclera, no appreciable cervical or axillary lymphadenopathy. Cardiovascularly, he had a regular rate and rhythm with no murmurs, rubs, or gallops. His lungs were clear to auscultation bilaterally. The abdomen was slightly protuberant, but soft, non-tender, no rebound or guarding, no appreciable masses or organomegaly, and there were faint bowel sounds appreciated. Neuro, no deficits to note, and his extremities, really nothing to note there, no rash and no swelling of either lower extremity.
Brian, you're doing an incredible job presenting this case. And one of my pet peeves is when someone says there's no skin rash, because I don't know what other type of rash there is. And you said there's no rash, so I want to applaud you for that. You're a couple years ahead of me because I made that mistake, and then Gurpreet Dhaliwal corrected me on a write-up a manuscript. All right, so Bhavya, it's our turn. Hopefully we both had a nice dinner. Hopefully you and your mom created something special. I had taco myself. We got some additional information here, and I was hoping you can just walk us through what you're thinking now with the past medical history, the social history, and the exam. Remember, I thought Greg and Robbie did a phenomenal job of working up the vomiting. And here we have an opportunity to maybe talk a little bit about the past medical history and the physical exam and how that informs your differential diagnosis.
Sure. So I think one of the things that is standing out to me right now is this family history of unprovoked DVTs. I'm just wondering kind of what's going on there, and it's definitely not something to overlook, I would say. Another thing I'm thinking about is, you know, he's had a 10-pack-year history of smoking, which again could make you a little bit more hypercoagulable, but he quit 30 years ago. And, you know, that long after smoking, you kind of have your rate of cancer decreases significantly. But still, in someone who's lost 10 pounds in 3 weeks, you know, I'm thinking, is this from him not wanting to eat? Has something been going on where he's just had a decreased appetite? Or is this something more significant to worry about? And in someone who looks like they might be slightly hypercoagulable right now and is losing weight quickly, I think, you know, all of us have to think about cancer as a consideration in a case like that. When I look at his vitals, you know, nothing is jumping out right now. So I'm not super worried that he's in shock from like a significant GI bleed at the moment, which is something else I'd be concerned about in a case like this, first and foremost. And so those are kind of the things that I'm thinking about currently.
Bhavya, I love that. Whatever you had for dinner tonight, it's giving you the energy to tackle this aliquot. What I love that you did is you talked about the patient's social history and smoking, and you rightfully noted that it's been several years since he smoked, so that should decrease the risk of smoking-associated cancer, specifically lung cancer. One of the most important skills that you'll develop next year is determining if someone is sick or not sick, and you did that beautifully. You used the vital signs, and you said, you know what? He doesn't seem to be in distress. We have time to think about this. The other comments I'll make here, one is in his past medical history, he has diabetes. And we know that diabetes can result in autonomic insufficiency, and that might manifest as gastroparesis. What I can't tell right now is why he's having difficulty with solids. and not liquids. But you have to think about autonomic insufficiency in someone with a past medical history of diabetes. Now, as we move on to his family history, it seems like there's been unprovoked DVTs in multiple family members. So I'll give you my 2-minute primer on how I think about deep venous thrombosis. The first step is to ask the question, is it provoked or unprovoked? And what will help you address that issue is thinking about Virchow's triad, which includes surgery, trauma to the vessel, or hypercoagulability. So Bobby, if I told you someone was on a long flight, developed tachycardia, had lower extremity swelling, you would say, well, that was sort of a provoked DVT. The patient wasn't moving. It was stasis of Virchow's triad. If I told you someone had a cholecystectomy or had a hip fracture and a hip repair, then develop a DVT, you say, Reza, that's provoked. In all comers, once you say someone has a DVT, they get minimum of 3 months of anticoagulation. And what we see is the direct oral anticoagulants are a great alternative to Coumadin, because you don't have to measure, lab tests to make sure the patient's therapeutic. So we're saying this is unprovoked. When you have one unprovoked DVT, what the recommendations are is that age-appropriate cancer screening has been done. So we have to ask Brian, hey, Brian, did this patient ever have a colonoscopy? Because the patient's over 50. In someone with a 30-pack, if someone had a 30-pack year smoking history and was over the age of 55, then you would get a CT scan of the lungs to evaluate for lung cancer. Because again, that's sort of recommended by the US Preventative Task Force in someone with a strong enough smoking history, and if you find a blood clot for sure. Then you can think about some of the inherited conditions. These include prothrombin gene mutation, factor V Leiden deficiency, protein C, S, and antithrombin 3 deficiency. These are sort of your hereditary hypercoagulable states. The truth is, factor V Leiden mutation and prothrombin gene mutation, they don't give you that much of an increased risk for clotting, unlike the protein C, S, and antithrombin 3. And it's tricky how you should measure these values, because in the setting of clot, you might have aberrations in the protein, C and S and antithrombin 3 levels. The other one specific diagnosis you should always consider when someone has had multiple clots is Anti-Phospholipid Syndrome. That too is a tricky diagnosis, and we haven't heard from Brian exactly what type of investigations were done for this patient's clots, but that you send a lupus anticoagulant, a beta-2 glycoprotein, and a cardiolipin. But again, it's difficult in the setting of clot and in the setting of anticoagulation. So we just have to keep that in mind. And if you ask, how could the clot relate to abdominal pain? We're not there yet, but you start thinking about some kind of mesenteric venous thrombosis that may be causing increased pressures within the peritoneum. The reason I spent so much time on the clot and the family history is because I don't have too much to comment on the physical exam. All I can say is that there's no evidence of elevated right-sided pressures as may occur in pulmonary embolism that leads to pulmonary hypertension. We see that the cardiovascular system is totally normal. And with regard to the weight loss, he has been vomiting. So I don't know if that's related to his vomiting, or like you mentioned, Bobby, if there's like an underlying occult malignancy that we have yet to diagnose. So I think what's going to be helpful going forward is obtaining additional labs like a CBC, CMP, and some coagulation studies, and then going from there. So Brian, why don't you give us some more information?
Yeah, it's just to answer some of those questions too. He had not had a colonoscopy yet. And our understanding, he got a lot of the workup done for the DVTs at another center, but our understanding is that all of the hereditary thrombophilias were basically ruled out, as was Anti-Phospholipid Syndrome when we had seen him. So just some labs here, getting to the CBC, the hemoglobin was 11.3 with an MCV of 90. The white count was 5.1. The platelets were 239. The white count differential was notable for an absolute lymphocyte count of 290 The BMP showed a sodium of 136, potassium of 3.4, chloride 98, bicarb 26, creatinine of 0.53, and his BUN was 5. His liver labs were all totally normal. The HIV was negative, and an EKG was normal. And do you all want to hear imaging right now?
Sorry. Oh, yeah, I think that would be helpful.
Cool.
That's okay, Brian.
Yep. So CT of the abdomen and pelvis with IV and oral contrast was performed, and it was read as severe confluent retroperitoneal and mesenteric adenopathy, and a large soft tissue mass causing high-grade proximal duodenal obstruction. The soft tissue mass measured at 10.4 by 5.6 centimeters and was noted to encase the aorta, renal vasculature, and SMA. And it was confluent with the Unsnet process of the pancreas. And then a CT chest was done, which was unremarkable, with no intrathoracic or axillary lymph node enlargement.
Brian, it's amazing how one, I'm really glad you gave us the imaging, but I'm also it's just amazing reflecting on before I come to Greg, just how all of us probably felt. And I will say I struggle to define what a pivot point is with any clarity. Like I struggle to give you a comprehensive definition of it, but I think the closest I can come is that feeling that you all just got right now. You're like, oh, okay, I have something to work with. That is a pivot point. But Greg, I think we owe it to this to the diagnostic process to actually take a second to make sure if we're not missing anything else. So before you and I study the CT findings, let's give the rest of the labs a close scrutiny that they deserve. So anything that jumps out to you with the labs?
Not a ton. We highlighted the hemoglobin there. I don't know what the absolute lymphocyte count should be, but it's not highlighted. So,
you said the magic words. I don't know. I love it.
And
I don't know either,
the BMP, the creatinine's pretty low, and but nothing's ringing any bells in my head for those.
Yeah. I agree with you.
Normal EKG is reassuring.
Agreed. Your mind processed that information very quickly, and I think that you're essentially saying the labs aren't giving me any signal to the process, and it's a sigh of relief, right? Like it's a sigh of relief that there are no SD elevations on the EKG. It's a sigh of relief that there doesn't appear to be a marked anemia here that would make us worry about GI blood loss. But I agree with you. It's almost like, okay, we can really focus on the CT findings. I think I will tell you that as an attending 2 years out, I don't have a very comprehensive, thorough approach to approaching retroperitoneal mesenteric lymphadenopathy with the duodenal mass. It's encasing the pancreas and the aorta. I don't really know how to begin to. I think I have an idea about how to think about that, but I would venture to guess that as a fourth-year medical student, I would be like, I don't know. But that does not mean that we can't take the opportunity to practice. So this is very, very complicated, but I would love for you to take it as far as you can, and you and I will. I'll try to layer on to anything that you have. So take it as far as you can.
All right. So at the core, it sounds like it's a duodenal mass that would explain many of his symptoms. It explains why he can't keep food down, but can't keep liquids down. Explains why he's progressively vomiting more often. I will assume that this mass is a malignancy. That explains why he's recently more hypercoagulable. Any family history, I wouldn't expect to present when he was, 60. So it's encasing the aorta, SMA, renal vasculature. I don't know. To me, that's bad. It doesn't explain why he would any of his other symptoms that I can think of. Lastly, if it's a GI malignancy, which it sounds like it is, he's probably bleeding a bit. That would explain his hemoglobin. In terms of the source, it looks like it's a duodenal mass was confluent with the pancreas. I don't know. It sounds like it's GI. It doesn't have the textbook features of a pancreatic mass, like painless jaundice or anything like that.
100%. I'm going to ask you a question before I reflect with you. This is a tough one. Um, what do you think about when you say GI cancer and there's such extensive disease? What do you think about the fact that we didn't hear anything metastatic to the liver, which is a very common place for GI cancers to go? So cross-check your hypothesis of a GI malignancy with such extensive disease, but not going to the liver.
Mm. What do I know about this? So I know like colonic malignancies go to the liver. Somewhere in my brain, I feel like is there a place in the GI? And I know this is a question. Is there a place in the GI that you can have a malignancy that doesn't drain to the liver?
I would stand, but it's been a long day. I'm tired.
Me too. Post call.
There we go. You don't have to know things to ask the right questions. And if you Google that, that would take you down the path that I'm going down. I'm not going to tell you that it's the right path because I'm not sure either. But that's the key question here. Sometimes studying where disease is absent is more informative than where disease is present. And the dominant disease here is in the retroperitoneal. This is a retroperitoneal process. How do we know that? We have retroperitoneal lymphadenopathy, and remember the pancreas and duodenum, the pain in those organs radiates to the back as a reminder that they're primarily retroperitoneal. There's some parts of the duodenum and some parts of the pancreas that are not retroperitoneal, but in the presence of retroperitoneal lymphadenopathy, our bets are this is a retroperitoneal disease. You're right to say that when you hear this, you should think cancer. And I will also say that when you hear retroperitoneal mass, period, the patient has a 90% chance of having malignancy. Why? Not many infections have access to the retroperitoneal space. Like, how do you get there? It's hidden. And so the burden of malignancy is very, very high in those instances. Local malignancy in the retroperitoneal accounts for a small fraction, and the local malignancy is really sarcomas and neurogenic tumors. Metastatic disease is by far and away the most common, and the three organ systems that metastasize to the retroperitoneum are the GI tract in the rectum, which is what you were alluding to, which is not drained. It's not drained by the portal vein, but drained by the systemic circulation. So rectal cancers go to the retroperitoneum, gynecological tumors like cervical cancer, and genitourinary tumors. So this would include things like genitourinary, so things like testicular cancer, ovarian cancer, renal cancer, prostate cancer. So GI, GYN, GU. Another metastatic cancer that looms large in this case is lymphoma, and lymphoma originating in the GI tract, in the retroperitoneum, is actually fairly well described. Now, don't get me wrong. There's a non-malignant differential to run through. If you're playing the odds, a non-malignant differential to run through in a retroperitoneal process is IgG4 disease, which we won't talk about too much, and Erdheim-Chester disease. Again, rare, but the buzzword for Erdheim-Chester is encasing the aorta. It has this characteristic imaging phenotype. So we spent a lot of time reflecting, and I would love for Brian to take us to the next level analysis before the diagnostic test is performed. But if you were to take away anything from this conversation, is Greg's reflex to translate this into cancer is spot on. The retroperitoneal space, 90% is malignancy. Think local tumors, sarcoma, and neurogenic tumors, but the vast majority are metastatic disease, metastatic from the three Gs, GI, GYN, and GU. And don't forget the other G, genitourinary, and then lymphoma.
Awesome. So the next information, he underwent an endoscopic ultrasound guided FNA of both the mass as well as a periportal lymph node. The FNA of the mass said rare acinar type cells with background debris, not further diagnostic, recommend repeat biopsy. The periportal lymph node, it said rare atypical cells concerning for malignancy, but not further diagnostic and recommend repeat biopsy. Some more labs started to come back. An LDH was within normal limits at 145. A CEA and a CA19-9 were within normal limits. And then a CA125 was significantly elevated at 310.3. And to get back to that absolute lymph count, so his absolute lymph count stayed pretty low throughout hospitalization. And his CD4 count was in like the sub 100s kind of for a few weeks during this workup, I'll say.
And Brian, did you have an HIV test for him?
It was negative.
It was negative. Wonderful. And your next aliquot will reveal the answer. Is that correct?
Yes. Yep.
All right. Wonderful. So, Bhavya, I don't think I know what the diagnosis is, to be honest with you. But we'll do our best to try to tackle and decipher the information that Brian shared with us. What I would encourage the chat to do at this point is sort of maybe list their top 2 diagnoses and what their next diagnostic test would be. So Bhavya, let's see if we can tackle this. I thought that Greg and Robbie did such a phenomenal job of setting us up for the differential diagnosis. Here, you know, I'm struggling to even ask you a question because I'm thinking of, if I were on the receiving end, how would I be able to answer questions related to this? That being said, I'll still ask you, Bhavya, what does this information do for you? You know, we were most concerned for cancer. We have a high CA125, and we have a biopsy that's equivocal.
Mm-hmm. Yeah, so the CA125 confuses me because I usually associate that with ovarian cancers. Mm-hmm. And so I'm not exactly sure what else that could show up in for a male. There's probably some kind of germ cell or something that it might be associated with. I think in terms of the biopsies, because it was an FNA and I didn't get enough information, I'd want a core biopsy to make sure that we didn't miss something, and we'd kind of have to go from there because, like you said, it's not too much more to jump off of at this point, so we need a little bit more information.
Bhavya, you're way ahead of where I was, and I mean that like genuinely. You're absolutely right, especially when it comes to lymphomas. Almost, I would argue that an FNA should never be performed, given the low test characteristics of that study. A core is good, but if you're really concerned for a lymphoma, an excisional lymph node biopsy is the best, because that will also allow you to evaluate the architecture of that node. And I've been in cases where an FNA missed and delayed the inevitable diagnosis of lymphoma. Core is better than FNA, but the ultimate would be an excisional lymph node biopsy if you are concerned for lymphoma. These tests, we're talking about misnomers in medicine. I feel like these tumor markers are misnomers, meaning that I've seen patients with, in fact, it was at SIADM last year, Robbie and I discussed a case of a patient with a very elevated CA125 from Africa and actually had an ovarian mass that ended up being diagnosed with tuberculosis and had a tuberculoma. So you have to take the tumor marker with a grain of salt. I think it's helpful in cases where you're following treatment to a specific malignancy, or if you're dealing with an anterior mediastinal mass, but really absent those, they don't have the best test characteristics, though we won't ignore that. I think what I would love to do here is just run the list that Robbie created for us. And, you know, he said his pivot point is the retroperitoneum. It's not the easiest site to biopsy, and of course there are complications from there. So the question is, can we make any more progress without invasive testing? One thing we should do is a scrotal exam, just to make sure there isn't any type of testicular cancer, although we expect that in our younger patient population, that may be metastasizing to the retroperitoneum. With regard to IgG4 related disease, I love this thought. This disease, actually a case was presented to Uncle Bob at SGIM in 2014 of a patient with a pancreatic head mass, who Uncle Bob ultimately diagnosed with IgG4 related disease. So we should send the IgG4 levels in the subtypes, because there's IgG1, 2, 3, and 4. So that's a test I would request from Brian. Even if the serum IgG is not elevated, you can still have IgG4 related disease. And you might ask the pathologist to tell us if there's any evidence of lymphoplasmacytic infiltration. That's the hallmark of IgG4 related disease. With regard to lymphoma, the LDH is normal. I don't think it has the best test characteristics for lymphoma, but it's telling us that you're not having aggressive cell turnover that might cause an elevation in the LDH. So besides sending the serum IgG levels, besides doing a scrotal exam, can we do anything else? Robbie mentioned Erdheim-Chester's disease, which is a non-Langerhans cell histiocytosis. And as Robbie mentioned, that thing loves to coat the aorta. Patients may present with, I believe it is diabetes insipidus, and even chemosis and some ocular findings as well. So Brian, besides asking for some serum IgG levels and doing a scrotal exam, I'm not sure I have any much more to add to Bavia, and I think we're still very concerned for a cancer. So if those tests don't come back positive, I would imagine that you would reinvestigate with some kind of invasive procedure.
Awesome. Thank you guys so much. I really wish we had you all on our team when we were working this patient up. So he next underwent a CT-guided biopsy of the mass. And with the following preliminary path read, it's at histiocytic granulomatous inflammation positive for mycobacterial organisms. And then he ended up getting tissue culture, blood culture, and stool culture, which all grew Mycobacterium avium. And he was diagnosed with disseminated MAC. He was then started initially on amikacin, levofloxacin, and azithromycin. And his CD4 count really puzzled us throughout the hospitalization, and we were definitely thinking cancer kind of throughout. So his CD4 count got kind of down after we had diagnosis. It got down to like 9, and he's still being worked up. It's thought to be an idiopathic lymphocytopenia. It's still being worked up.
Brian, I want to give you a big hug. What a case! Wow. Before I reflect and pass the mic to Robbie, I would just love to get Bavia and Greg to just reflect on this case and just do a mini cognitive autopsy of our thinking. So Bavia, why don't I give you the mic first? What's your reaction to Brian's phenomenal case? And what's your cognitive autopsy?
Sure. Well, thank you, Brian. This is a fabulous case and so much fun to think about. I think I was, when you asked about the HIV status earlier, that's the first thing I think about when I hear that he has MAC, because he's HIV negative. There's nothing else I can see that would put him at extreme risk, and so that really confuses me, or that's something that jumps out at me. And I guess it's a really good reminder for me that can still be happening, even if it's not something you suspect right off the bat. But yeah, very much caught me by surprise.
Me too. I'm going to give the mic to Greg, but what I'm learning from all these CA-125, maybe it should be a mycobacterium marker. So Greg, what's your reflection?
Yeah, I'm trying to unpack at what point we should have broadened our thinking. And I am not sure if, at least for me, if there was. For me, my pretest probability was so high that he would have a malignancy given his hypercoagulability and a mass that, man, it's hard to think like at which point I would have thought I think if I kept seeing his CD4 come down, I think that would trigger me to work it up. But I mean, I just discarded it because the mass was so high. So it's hard to say. I think it's interesting that you would get the diagnosis on biopsy either way. So I think that, and I'm somewhat reassured by that was the process, but maybe the etiology was different.
I need some time to reflect on this, but I want to say it was an absolute joy discussing the case with you, Bobby and Greg. I think you were both superb. Brian, this is just mind blowing, honestly. I will say though that that I think it's hard when you get the diagnosis wrong in these kinds of exercises, not to be open to the possibility that your reflection is influenced or biased by your ego. We all want to get this right, and so I will share my reflection now, but I'm open to it being influenced by everyone's sense of wanting to get things right. But I would say my honest reflection right now is it would have been wrong to get the diagnosis right. I think it would have been wrong to say my diagnosis before the biopsy is a non-tuberculous
Robbie,
mycobacteria.
can I give a quick interjection?
Yeah.
You remember it was almost a year ago where our colleague said, my attending would say, Alibaba, it's TB, why do all these tests?
If you want more context for that comment, which is amazing, it's at the end of the SIDM episode, and it's just absolutely beautiful. But I would say, again, like, I think you cannot judge the process by the outcome. And this is one of those cases where you're very, very grateful to the fact that you always maintain a broad range of possibilities. But any biopsy result, it could have been lymphoma, it could have been metastatic pancreatic cancer, which the chat was about. It could have been many different things. And I think the mistake would have been to assume that it's infection without doing the best possible job to make sure it's not malignancy. But I'm really inspired by these cases because they go to they really go to show you that our journey on medicine is endless, and that you'll never ever be able to say before the test that actually tells you the answer that you'll ever be 100% confident of it. So I'm humbled. I'm open to this reflection being biased by the fact that we're all invested in trying to get this right. But I'm actually very proud of the answers that the chat committed to and that we committed to, because I think if you had said Mycobacterium avium for a case like this, I think 99 times out of 100 you would be very wrong and you may end up harming a patient. But I'm really glad that Brian brought us the 1 in 100 so we can learn as much as possible, and I really appreciate that.
So thank you so much, Robert. We will go to Jack in a second, and then after Jack, we'll have Anand Patel. He said there's a lot of questions regarding hypercoagulable workup that he'll give us quick teaching, but maybe we'll do Jack, then Anand. And before all of that, I just have to say one thing to Brian. Brian, I told you it was Robbie's birthday. I was expecting a urinary tract infection due to E. coli, but you didn't give it to him. So that's on you, Brian.
He made it the most memorable it could be. Thank you, Brian. This is awesome.
Awesome. Wow, what a case. There is a big chunk in here highlighted that I'm going to go skip over first and then edit after Anand Patel gets the chance to speak. So I will handle the other teaching points here. I think this case started somewhere where I think we find ourselves very often with nausea and vomiting, and ended somewhere where we find ourselves very infrequently, which is MAC. And I think that goes to highlight just the range of diseases that can present with nausea and vomiting, and emphasizes the pearl that we learned at the beginning, which is that when you're faced with a patient who has nausea and vomiting, focus not on the nausea and vomiting itself and on the company it keeps. Right? Nausea and vomiting with chest pain is a much different schema in our minds than nausea and vomiting with a headache. And so those accompanying symptoms help us localize where the nausea and vomiting might be coming from. And then what do we do if a patient presents with nausea alone and it has no company with it? That's when it's worth running through the checklist of sinister causes of nausea that may not be readily apparent on your initial exam unless you go looking for them. And that would be a problem in the brain, such as the area postrema. It could be a malignancy dwelling anywhere inside the body, especially within the abdominal cavity, or it could be the acute coronary syndrome from myocardial ischemia. We then talked about a DVT, which again I'm gonna punt to the expertise of Anand here. I think as we then sort of pivoted into the abdomen and found this pivot point of what is this mass, we learned that not only is it crucial to focus on where disease is, but to also ask yourself where disease isn't and come up with a reason why. And in this case specifically, we saw that there were signs of a potential malignant process within the abdominal cavity, but that the liver was spared. And so whenever you find that combination of an intra-abdominal mass plus a clear liver, it's worth asking yourself, is this a retroperitoneal process that's happening? And specifically, a retroperitoneal mass can be oftentimes from metastatic disease from the GI system, the gynecologic system, and the genitourinary system. or it can be from a primary retroperitoneal process, which includes malignancies like a sarcoma, a neurogenic tumor, or a lymphoma, or it can be from a non-malignant RP mass, including IgG4 disease, as well as granulomatous processes like mycobacterial infections. And then the last thing is just a pearl that came out of the chat there at the end, which is whenever we find ourselves facing elevated tumor markers, we have to interpret these in the setting of our pretest probability, right? CA 125 we may associate that with a specific malignancy like ovarian cancer, but in the absence of a high pretest probability for that, we can't necessarily say, okay, we have to go hunting for cancer because it can be elevated for other causes itself. And with that, I'm going to pass it over to Anand to learn a little bit about how to evaluate patients with a prior DVT.
Thanks, guys. Brian, incredible case. I was right there with everyone else, not expecting that hard left turn, and I'd put on my oncologist hat a little prematurely. So a lot of questions had come up about hypercoagulable workup. And the first thing I want to do is there's an incredible review article written in the New England Journal in 2017 by Dr. Gene Connors that talks about thrombophilia testing. I encourage all of you to read it. The big takeaway, the too long didn't read, is it's very rare that thrombophilia testing will change what you're going to do for a patient acutely in the hospital. So with that in mind, sending off hypercoagulable testing while someone's hospitalized is a pretty low yield effort and unlikely to change what you're going to do for the patient. The caveats to that, I would say, are anti-phospholipid syndrome, especially if someone's having multiple clots and you have to think about something like catastrophic anti-phospholipid syndrome. And the other reason that matters is because more and more we're finding evidence to suggest that warfarin, for whatever reason, tends to be the best anticoagulant to use in anti-phospholipid syndrome, even more so than low molecular weight heparin or any of the NOACs that we have. So with that in mind, the other question that came up a lot was, what testing can you send in terms of a hypercoagulable workup when someone is already on anticoagulation? The way I remember it is if you're checking factor levels, they're going to be thrown off. So if you send off something like a protein C or a protein S when someone's on anticoagulation, it could be erroneously low. It's low because we're anticoagulating someone. Whereas if you're sending off a genetic test, so something like a factor V Leiden mutation, a prothrombin gene mutation, those are going to be accurate, no matter what, whether you're on anticoagulation or not. The one that kind of splits the difference is anti-phospholipid syndrome testing. So your anticardiolipin and your beta-2 glycoprotein shouldn't be thrown off. Your lupus anticoagulant testing can be thrown off by being on anticoagulation, but most labs, most coagulation labs are able to correct for that. So they're able to run the test such that when they do their mixing studies, et cetera, they can say that there's a likely presence of a lupus anticoagulant, even if someone's on anticoagulation. To make a diagnosis of antiphospholipid syndrome, you need to have positive antibodies at least 12 weeks apart. So, if you're working up someone on the inpatient side, you may be able to give them a presumptive diagnosis of APLS, but it's very important that they have outpatient follow-up and testing done about 12 weeks later to make sure that those antibodies are still elevated to confirm that diagnosis. And I will leave it at that.
Anna, that was absolutely amazing. And I think your ability to take such a complex concept and explain it in like 3.5 minutes stands alone, my friend. I can't wait to re-listen it over and over again. I appreciate you very, very much, especially the pearl about APLS. That was the testing of APLS and the need for repeat testing. That was very, very helpful. All right, folks. Well, we hope you have a great night. Thank you so much for joining us. Again, Brian, very, very grateful to you presenting this great case, and to Greg and Bhavya for a fantastic discussion. And we'll hope to see you all tomorrow. Good night.
Happy birthday to you. Happy
birthday to you. Happy birthday
Thank
Yay.
Laugh.
Robbie.
He's out of here.
Happy birthday
Birthday
to you.
He definitely left.
Yeah.
Bye, team.
Bye.